first of all, can I just ask you to introduce yourself and just say your name, your role, and your sort of areas of interest in the NHS?
So I'm Bassett Sharrock. I'm a neurologist and I have an interest in multiple sclerosis, and I work in Sheffield. My main really research and clinical interest in MS is stem cell transplantation, and I work with Professor Snowden really closely.
Mm-hmm. Perfect. So first of all, can you just talk through what actually is stem cell therapy, specifically AHSCT, and what's involved in the treatment?
So it is the process by which we harvest the stem cells from individuals, and then we store it. And in condition where the immune system is responsible for causing an illness like multiple sclerosis, then changing the faulty immune system with a fresh one, we hope would eradicate the main cause of the illness itself. It doesn't really eradicate the illness itself. So the process really will involve harvesting these stem cells, which are pure cells, which reside deep in the bone marrow, and they're really not being exposed to the illness itself. And we harvest those and we store them, and then we give individuals a high dose of a chemotherapy, which will really eradicate all the cells, immune cells in the body, good and bad. And then we reinfuse with stem cells, which we harvested and stored back into the blood. And then they're very clever. They go and find their way around the body and go to the bone marrow and start producing new cells. And by doing this, you really you give the body a fresh start in terms of allowing the body to have a new immune system, which has not really been exposed to whatever caused MS in the first instance. And by doing that, you will we hope that you will arrest really the illness itself. And that's why it's really very important for you to try to use this process early into the illness before significant damage has affected the body. Mm-hmm. And then we think really that this process will not only really stop the illness in the majority of the people who receive it, but also it can help improve the level of disability for those patients who had become slightly disabled by the process.
Mm-hmm. Brilliant, thank you. That's a really good explanation of it. So in terms of who it's suitable for, we're often contacted by people with MS on our inquiry line asking if this is something that they would be eligible for. So what types of MS can this treatment actually work for?
You need to think about really what's really causing the problem in a particular patient's case. So if inflammation is the main cause of the problem at a particular stage in somebody's illness, then this treatment, being a very powerful anti-inflammatory treatment, will hopefully stop that and help patients. But if there is no evidence of active inflammation in a particular individual, then this treatment might not be that helpful, because it doesn't really, although really it's called stem cell, these cells don't go and repair damaged part of the brain and spinal cord. They can only really modify and rectify a faulty immune system. So really, we need to think about really how much of a faulty immune system is causing ongoing damage to the brain and spinal cord before contemplating the use of this treatment.
So a lot of people with relapsing remitting MS are on disease-modifying drugs for their MS. So how does this treatment compare in comparison in terms of how effective it is?
So we think it is far more effective than any other therapy that we have at the moment, mm-hmm. although there isn't really any trial evidence to support this statement 100%. So we have trial evidence to suggest really this treatment is far more effective than those patients who really receive the standard disease-modifying treatments, so first-line platform therapies, interferon, glatiramer, dimethyl fumarate, teriflunomide, but also some of the stronger therapies like fingolimod and natalizumab. What we don't really have is direct head-to-head comparison between stem cell treatment and ocrelizumab and alemtuzumab and cladribine. And So individual studies suggest really that stem cell treatment's far more effective, but the best way really to confirm that this treatment is far more effective than the others is to do a head-to-head comparison. And that is the answer which we hope we will get from the STAR-MS study, which will hopefully start in the UK in the next few months.
And can you talk a bit about the practical side of things? So how long does it take to have this treatment? And can you talk through the recovery process?
So it does take a bit of time, and you need to be careful to offer the treatment to the appropriate really sort of patient cohorts. So a patient who has very active inflammatory disease, presenting with a lot of relapses, evidence of MRI scan disease activity, will benefit from that treatment. So you select patients very carefully. And then you need really to make sure, because it's really a tough treatment, you need to make sure that the patient who received this treatment is fully aware of the nature of the treatment and the implications, both in the short and the long run. So for instance, the treatment will have an effect on fertility, both for males and females. So it's very important for you to discuss that with the patient up front and mitigate for any risks by storing sperms and eggs and so on and so forth. And then once you really you're really satisfied that the patient is fully aware and of the nature of the treatment, then you need really to assess the patient's ability to receive the treatment. So we do various baseline assessments in terms of assessing the breathing and the heart status and so on and so forth. But the treatment really proper starts by getting patients into the hospital to harvest their own stem cells. And we do that by giving the patients certain drugs which will mobilize the stem cells from the bone marrow into the bloodstream. And then we harvest that from the bloodstream from a large vein. The process doesn't take long, really. At the same time, because the drug that we normally use to mobilize the stem cells can cause inflammation, we give the patient a small dose of a chemotherapeutic agent called cyclophosphamide. And then once we've harvested the stem cells, we allow the patient a bit of time really to recover. Normally, they will find benefit from the small dose of cyclophosphamide they have received, and they get better in terms of the physical activities. A lot of patients really report that mentally they're feeling better. And then we bring patients back into the hospital a few weeks later to give them now a very large dose of chemotherapy, which will now eradicate the faulty immune cells from the body. And by doing that, they will have no effective immune system. So they have to be kept in isolation for, on average, about 4 weeks. Once they've received the chemotherapy, we put the stem cells back into their peripheral veins, and then allow really these stem cells to go and go to the bone marrow and start producing immune cells. And we monitor patients very carefully. This is a very critical period, really. Patients will be prone to infections and so on and so forth. So the large dose of chemotherapy will make them feel unwell. They get sore mouth, and they get really loose stools, and so they really feel rough at that time to various degrees. And that's why we have to make sure that the patients are really fit to undergo this treatment to start with, and support them really in the best way that we can. And then patients can be once we quite content that the white cell count has recovered and they're not at risk of getting infections, we can allow them to leave the hospital, but they will be monitored very carefully on a weekly basis with repeated blood counts and so on and so forth. And we allow them time to recover. They need a lot of physiotherapy and both physical and psychological support. And that will probably take about really 3 months. So the process takes about 3 months really for them to feel really back to normal selves. So it is really a long process.
In terms of stem cell treatment for people with progressive MS, is there any other types of stem cell treatment that's currently being researched that might be more suitable for them?
Patients who have significant element of inflammation, but they have progressive disease, will probably gain some benefit from stem cell transplantation. The benefit probably will be limited compared to those patients who have relapsing remitting inflammatory disease. But those patients who don't have really evidence of inflammation, then the only other treatment which is currently being trialed is mesenchymal stem cells, and these also a different stem cells which we all have in our body. So mesenchymal stem cells are not responsible for building immune system, but they are really they will provide support to neural tissues in the brain and spinal cord, and there is really very encouraging evidence from phase 1 and phase 2 studies suggesting that it will be effective, but it is really not a standard treatment at the moment. It's not really offered to patients on clinical grounds. It's been offered to patients in clinical trials.
There's lots of articles that often come up in the media that sort of portray stem cells as this sort of miracle cure for MS. So what are your views on that, and what does the research say in terms of how effective it is?
Well, it is, the evidence suggests that it is far more effective than anything else that we have at the moment, but in the right patient group. Patients who have active inflammatory disease, despite the use of standard therapy, the benefit really that they will gain from receiving stem cell transplantation is certainly far more than receiving the majority of the drugs that we can offer them otherwise. I did allude to a little bit earlier that we don't really have trial data to support my claim in terms of efficacy of the treatment against ocrelizumab, alantizumab and cladribine. But as I said, really, we hope that STAR-MS will be able to address that particular question. But it is really far more effective than anything else. Now, despite all of this, is not a cure, and not everybody who received the treatment will remain really soft without evidence of the illness later on. So in the first few years, the majority of the patients will experience no further evidence of disease activity. So that is no evidence of relapses, no evidence of MRI scan disease activity, and no progression of their disability. But unfortunately, a small proportion of patients, probably about 20% or thereabout, really, of the illness will emerge again. But even those patients, when the illness emerge again, really, it will not be as aggressive as the illness that they may have had before, and they respond really to treatment probably a little bit better. So it is very effective, but it's not a cure. So it's not a miracle cure.
Mm-hmm. Do you think, sort of going forward, if you do have trials that compare it to some of the stronger drugs and it shows that it really is quite effective, do you think it's going to become a treatment that will be used more widely for people with MS?
Indeed. At the moment, it is really like a third-line treatment based on the current guidelines that we really work to in the UK. We think really the previous study that we did, called MIST study, which proved really that treatment is more effective than, say, dimethyl fumarate, efimosfermin, and natalizumab. We think really those patients who have active disease and despite the use of first-line therapies, the treatment ought to be offered to them really as a choice with the other therapies. But we sincerely hope really that once the STAR-MS study is finished as well, and provided really the results is what we anticipate them to be, then anybody who's got active disease despite the use of standard therapy, then if you want to escalate the treatment, that should be one of the options. And of course, really, the patients and their neurologists would need to discuss that and see if this is the appropriate escalation plan for a particular individual.